Hi, everyone. Happy Friday, happy Friday, happy Friday. I'm Clay Farris from MostlyMedicaid.com, bringing you the news from a wonderful Medicaid world for August 7th, 2026. If you're new to the show, this is Medicaid On The Brain. I cover Medicaid news. I'll give you some job hunter tidbits. We'll do acronym of the day, and we'll do mission possible. Also, if you're new, if you want a copy of the Intel report that we put out each and every week, it goes through all the stories. They're detailed, highlighted. We summarize them for you. We put these out each and every week in our different LinkedIn community groups and our peer groups. So look up on the screen if you're checking that out, or just look for them online, and then you'll kind of get on the distribution list. And you can follow along as I go through the stories. I'll be calling out the numbers from each of the stories that I'm covering. They're numbered the same as in your Intel report. First up, let's do some warm-up items. Let's look at item in your Intel pack number 1. This is Medicaid cuts and private equity-owned care. This is a thread that we track a lot here. And this is actually from pestakeholder.org. So literally the point of view here is private equity worried about all its money with the quote-unquote Medicaid cuts. What are they going to do with the profits? And so you have investors looking at our Medicaid space, let's be very clear, as a giant investment market. And in their view, they're looking at what they think are reductions in federal spending over 10 years to be about $911 billion. They're focusing in on things like long-term care, since Medicaid is the primary payer of things like nursing home care. And there's this little nugget in this story. Private equity now owns 13% of U.S. nursing homes. They're also major players in IDD services companies like Savita, Help at Home, Broadstep, and they have a big stake in home care and private duty nursing companies. Companies like Team Select and Aviana Healthcare are called out in this story. And of course, one we've all been watching recently, the article calls out autism therapy centers, more than 500 of them that are private equity owned, with most of those acquisitions just in the last 4 to 7 years. Other places you may not have known that private equity had invested: the PACE program, that's a program of all-inclusive care for the elderly. That's 30 of 196 PACE programs have private equity or venture capital backing them. The article goes on to list out other sectors like dental care, DME. And to me, this was shocking. 488 private equity-owned hospitals. So this is really just kind of a data sheet, this article is, on how far the tentacles of private equity have gotten into our space. Which, remember, we all pretend like this is a virtuous safety net, when really it's an investment vehicle by the people that have the power, whether or not we look at it that way. So swallow down that little FYI this morning, and let's move on to item 2. Item 2, HHS defers more than $1 billion in Medicaid payments to California and Minnesota, pending review of high-risk claims to crack down on fraud. This is really a continuation of the story from, I think, about a month ago, but we're starting to get more details. It's interesting because California's gotten fairly proactive on how it's reporting what it's doing on fraud now. You had all this saber rattling by Governor Goodteeth. No, we're not going to do it. We're going to fight evil Trump. And now he's like, okay, I guess we really want our money. If you're in the LinkedIn sphere, you may have also noticed they're actually putting out, California, their HHS is actually putting out lots of posts about what they're doing to work with, say, their managed care partners on Medicaid fraud. So I won't go into too much details of this because we covered it on the show, but it does look like California is playing ball. And I think at a high level, really, what choice do they have? Now let's move on to MCO news and look at item 3 in your Intel report. This is Georgia Medicaid insurer reverses 20% therapy rate cut, but not for all providers. Don't you think it's interesting they don't name the Georgia Medicaid insurer? It'd be much faster if they just say care source. That's one word, 2 syllables versus okay, that's like way less to just say the name. I wonder if the care source PR and marketing guys have some decent relationships with the local press. Anyway, what we're looking at here is they planned on reducing the rates for certain therapy providers by about 20%. But after some blowback said, okay, we won't do that if you're in a provider in an area with a network shortage. That change was supposed to happen in May, but as you can imagine, there was some negative press around all this. It would have impacted about 71% of the state's pediatric therapists for Medicaid members. But if you look at this from a shortage area, like an overlay of that, 40 of Georgia's 159 counties. Remember, Georgia's gigantic. Those counties don't even have a care source therapy provider. So if you are in Georgia Medicaid and you're a network or care source and you're not in an area where there's a shortage of providers, looks like this cut's going to hit you. Stick around for the interview. Sandra and I get into this, and she had some insights that I didn't even think of on this particular one. Let's move on to item 4. Oklahoma investigates fraudulent Medicaid enrollments. This is one I talked about, I think, last week, and we didn't have a lot of details. We have a little bit more this week. I'm trying to keep an eye on this one because to me it's fascinating. The core is there were thousands of Oklahomans who were fraudulently enrolled in Medicaid by some sort of international crime ring. That's all they keep saying. They say that no taxpayer dollars were lost and the crime was identified early on. Looks like all three MCOs in the state, that's Aetna, Humana, and Oklahoma Complete Health. I think that's a Centene plan wearing a local mask. But let me know in the comments if that's wrong. Looks like all three MCOs were impacted. So they all got some bogus enrollment from this mysterious international crime ring. According to this article, somehow there's some sort of data breach involving like an out-of-state system. That's all they say. Still not a lot of details if you ask me, but I'm going to keep an eye on this because it's fascinating. Who had on their bingo card Russian mobsters fake enrolling Medicaid members for MCOs. All right, now let's look at item 51. More in MCO news. Molina plummets as it expects to have, that's cut in half, its Obamacare presence. So this is one I want to emphasize a little bit because last week Molina was still, giving all the rosy picture of, oh, we're going to stick around and help Medicaid members. But then I think some of their, some stock analyst calls and reports and data and others and some of the Medicaid reform changes are, as they're becoming more and more apparent, Molina said, well, not so fast. Let's pull that back a little bit. Let's be a little bit more deliberate when we're placing our Medicaid bets. And this story is out of Reuters, and it's talking, it's on July 23rd. It said, look, actually costs are higher, and we're going to cut in half where we're going to place our bets on Medicaid lives. So that led to the stock falling about 12%. Molina thinks it's going to drop to like 6 states in 2027 where they have Medicaid business, and that's a drop from, I think, 13 or 14 states. They're going to walk away from almost $1 billion worth of revenue because, it's just too hard to keep making cash. Now, this is really just a continuation of the story of Molina's Medicaid membership going down anyway. And this is all before anything from HR 1 should be impacting Medicaid membership. So we don't have work requirements on board yet or some of the other things. So Molina took a big hit when California said, look, we're not going to push non-citizens into Medicaid plans anymore. That in and of itself removed $500 million from Molina's 2027 premium revenue outlook. All right, let's look at tech news for the week. Item 6 is one I wanted to cover last week but didn't have time. The Deloitte-run system denied Medicaid benefits for Michigan's disabled. Now Trump's law piles on. I think we got two things going on here. One is giant consulting firms like Deloitte also get to run super crappy tech systems for Medicaid. And this is a KFF article looking at a now 20-year-old Deloitte system for Medicaid eligibility in Michigan. Deloitte also runs similar systems in Tennessee and Texas, but this one really focuses on the Michigan Medicaid eligibility system where Deloitte gets $768 million. And according to this, 25 states use Deloitte to run or build computer systems that do similar Medicaid eligibility things. And the one in Michigan has been caught pushing members with disabilities into what the article terms skimpier benefits and denying coverage when it should not. Deloitte themselves, of course, deny there's any issue at all. And then, the journalist then wants to then say, and by the way, reform is going to make all this much worse. So now to me, the issue is the crappy Deloitte system, which we should fix that anyway, right? Like whether or not HR 1 ever got passed. All right, let's look at item 7. Pennsylvania announces $42 million for rural healthcare projects. Just to hit a couple quick highlights from this about this is in the state's rural health plan. This is, of course, ties to the $193 million that Pennsylvania got in the rural health transformation funding, which if you didn't keep up with that, the official Sunday school answer we're supposed to all say, the way we talk about this money is, yeah, thanks for the hundreds of millions of dollars, but it still doesn't help us with those Medicaid cuts. Anyway, Pennsylvania said they're going to release the first $42 million that they got of the almost $200 million from federal taxpayers for rural health transformation funding. So it's got that first $42 million bucks going to support 66 projects across the state. They can get up to $1 million each, so there's going to be a little over, a lot of them are going to be a little less than $1 million if you divide that in 66. So not a lot of detail yet on what those projects are. And this is another one, stick around. Sandra had some really good points on how we're going to measure all these different things because all these different programs from the rural health transformation are doing like widely different things. But stick around for the interview, so the discussion on that. Next item, let's do some pharmacy news. This week, let's jump to item 9 in your Intel report. This is appeal to change 340B drug discounts to rebates. Pharma loses appeal to make that change from drug discounts, rebates. If you've been watching the 340B saga, manufacturers have wanted to move towards a rebate model instead of the current drug discount model, which they say is highly disadvantageous towards them, and of course very opaque. We need more transparency. They also say there's very little transparency about all the shenanigans by the gigantic hospitals profiting and effectively doubling the spend of the program. But a federal appeals court judge says, nah, you can't do that. You can't just move it to a rebate model. You being the manufacturers. On July 21st, the D.C. Court of Appeals rejected the proposal from drug manufacturers to move to rebates instead of these upfront drug discounts. Essentially, it's saying that HHS needs to be the one to make these types of changes. For about 2 years, there's been some companies, J&J, Lilly, Bristol Myers, Novartis, others, they've basically gone rogue and said, we're going to do a rebate model anyway. And what that does, what that approach says, look, you're going to pay full price, and then if you can prove you deserve the discount, then we'll rebate it later. Similar to Medicaid drug rebate program, other HHS run drug programs. In addition to preventing the duplicate discounts that hurt the manufacturers, the plaintiffs argued this would bring transparency by creating some data that doesn't really exist right now. In a program that really needs a lot more transparency, this is probably where HHS is going to go next. If you watch what's happening, even the woefully incapable HRSA administration released an RFI in February. They got opinions on a rebate model. So Congress is trying to deal with this too. If you want more information of that, look at the Sustain 340B Act, which is legislation that is trying to do, among other things, increase transparency, get more definition about what an eligible patient is, and just bring much needed reform in general to the program. Our next item in pharmacy news this week is item 10 in your Intel report. Dexcom is first to join FDA CMS Health Tech pilot. So if you're not familiar with Dexcom, they're one of a handful of continuous glucose monitoring, that's CGM, equipment providers, and they're going to participate in the Tempo, TEMPO pilot for FDA, which is going to look at AI-enabled diabetes tech in the Medicare program. The idea of Tempo is combine tech with other things, like diet and exercise. It's being run inside CMS. And the FDA says they're going to bring up to like 10 different device manufacturers in 4 different clinical areas. This one is diabetes, so stay tuned to see who else may join the CGM pilot, as well as what else comes out of Tempo. Let's do some CMS news items. Let's look at Intel report item 11. CMS outlines more provider tax cutbacks. This is really just more detail on CMS promulgating rules to execute what was passed under H.R. 1. The overall impact is going to be about $246 billion in federal spending that happens under the provider tax schemes. In this particular story, it's about the 7.5, it's 7.5/7.5 test that some states use, that CMS wants some new reporting requirements also, and some oversight on some of these quote-unquote tests. So currently there's something called the 75/75 test, and it's a way to get around the 6% hold harmless threshold. It's going to get a little wonky. I'm going to get some of it wrong, but I want to kind of up the overall awareness of some of the stuff, and you guys can dig in more if you want to learn more. But it's the 7.5/7.5, 75/75 is a way to get around 6% harmless hold harmless threshold. I'm trying to unpack all this for those newer to provider taxes. So normally states can run these provider tax games where they tax their local hospital or whatever. They use that effectively as a state share to pull down more federal money. And of course, it's a magic money machine. You get back more you put in. So there's attempts to be some limits at this. So you can usually put in up to 6% if you're a provider of your net patient revenues. As long as so that keeps you in this safe harbor threshold. You're not going to lose any money, through the provider tax scheme. You're not going to get less than you put in, that kind of stuff. As long as it's no more than 6% of your net patient revenues. That's what we talk about, we call safe harbor. So the new safe harbor under H.R. 1, this is one of the places that has been targeted by reform to stop these financing games. The new safe harbor threshold is 3.5%. So you're going from 6% to 3.5%. And that's going to go starting to decline in October 1 of next year. And it's going to go down a 0.5 percentage point a year over 5 years. So all the people up in arms of this, they're just like hating that anything is being changed at all to this magic money machine. So it's going to go down to 3.5% starting October next year, 0.5% a year over 5 years. So by the time we get to September of 2032, we'll be down to 3.5% for safe harbor, coming down from 6% now. So still, you can do this game. You just can't score as many points as you used to. Hopefully you can see by all these tedious little details, we're not really trying to make sure we help members by getting all these missing Medicaid payments. We're trying to engineer a system that brings gigantic amounts of money using overly complicated calculations for hospitals, get more cash. But anyway, there's still ones that go beyond the 6%, and they currently slap a Band-Aid on it with the 75-75 test. Under this test, you can still do the provider tax game, even if you're violating the 6%, as long as 3/4, that's 75%, of the providers getting taxed in that group of the game you're playing did not get 75% or more of their tax costs from Medicaid and similar programs. So it gets a little wild, and we probably should get some experts on here to explain it. I can think of a few off the top of my head better than I am, but the bottom line is CMS is trying to make it to where you have no room to hide. Now, there's a law called HR 1 that was passed in our democratic process, whether you like it or not. It has things in it that people don't like, and CMS is walking out the details, and people are just scrambling to figure out ways to not comply with the law of the land. All right, let's move on to a couple things in state news this week. I think I didn't get to cover this in much detail last week, but Colorado owes $8 million back. That's your first one, item 12. This is tied to spending on in-home care program for members with disabilities. The federal requirements on this particular one are that caregivers have to log into a system that documents where they are and when they're logging in and the type of service. According to this article, Colorado doesn't require the use of something that would validate the location, like a GPS component. This has impacted about 1.3 million claims that the state has already gotten the federal payments for. So auditors looked at a sample of those 160 claims and came up with an estimate of $8 million that the state owes back. Again, stick around for Sandra and I talked about this one. I think there's some good things to talk about there, or good things for you to check out from that conversation. Let's also this week highlight Kentucky. Real quick, item number 15, your intel report is Beshear reverses 4% Medicaid Kentucky provider cuts. Beshear, there was an unanticipated corporate income tax payment that came in and saved the day. This led to a revenue surplus, and they're not going to have to make that 4% Medicaid cut they thought they were. It adds up to that overall surprise windfall is about $255 million. It's going to help float them in a couple places for one more fiscal year. Programs that are spared the chopping block include the senior meal program and the Michelle P. waiver. I want to learn more about that one. Stay tuned to see how the good governor figures out how to dance it all away again next year. Now we'll do one more item. Item 19, your intel report in New York Comptroller audit finds New York City schools failed to collect up to $431 million in Medicaid reimbursements for special education services. So according to this story from the Comptroller out of New York, they audited the public schools and they were not collecting money that they could be over 3 years. So instead of what we see a lot, which is getting too much money, they're not getting enough money that they should be. And this is because they didn't have the documents and they didn't complete the claims. So these are Medicaid payments. They could be getting, I think it's $431.6 million for students with disabilities, but that they just left on the table. Ultimately, the New York City public schools were submitting claims for less than half of the services that it could have gotten reimbursement for. You can also, in this story, you can open up like the individual education plans, IEPs, and see the shortcomings at that level too by the public school system, showing they're not even providing the services in 16% of the time for things like occupational therapy, speech therapy, physical therapy. Now, some of this in other categories in this audit, they may have actually done the services, but just didn't do the documentation needed to get paid for. But the majority looks like a lot of these weren't even delivered. Unfortunately, this is another example we've known all along, and we didn't do anything about it. There's a 2021 audit on the books, which identified 24 different corrective action plans. Only 3 of those got fully implemented. 8 were partially implemented by the time the comptroller looked at it again. Got a couple of items in the reform news bucket to hit this week. First one is going to be item 20 in your intel report. Trump public charge rule resets health tests for green cards this week. This is just look up item 20 if you want to read, if you want to go into some of the more detail. This one's been festering for a while, and it drives a lot of people in our space nuts. But if you're not familiar with it, the public charge rule is basically a principle in which approval, say you're trying to come into the United States, immigration approval to come in the United States is supposed to be conditioned on whether or not you would likely sort of be able to provide for yourself, whether or not you'd increase costs on the public safety net. And for a long time, I'm simplifying here, but for a long time, we really just kind of looked the other way on that. Well, this new rule would let immigration officials ask specifically the question if this individual or their family members might likely need Medicaid, CHIP, or SNAP, and then use that information to perhaps deny them access to the country, a green card, things like that, if they do think they would. Previous policies limited which public benefits you could look at in this question. And this is a time of not only Medicaid reform but immigration reform. So all these things are kind of coming together. And from a recent New York Times study, they found that nearly 11% of immigrant adults said they've stopped taking benefits because they were worried about losing their status. So people are already here. Department of Homeland Security says there's about $13 billion that doesn't have to be spent by U.S. taxpayers a year with this particular change on the public charge rule. Keep an eye on this one. It's sure to be a hot button issue if we can ever come up from air from all the other HR1 type changes happening. Our next reform item is item 21. OIG says states can boost oversight of Medicaid MCO fraud referrals. So according to a new report from the HHS Office of Inspector General, they want to see more help from managed care partners, Medicaid managed care plans, in sending referrals about potentially fraudulent providers to their state regulator partners. So if you've watched the show for a while, or any of my work, you know I say that we barely see referrals coming in from most MCOs. I've personally gotten calls from people working inside MCOs saying, hey, I want to report this thing, but my plan's telling me not to. What do I do? And this report talks about OIG finding a similar thing. It found that most states require MCOs to report any potential fraud, but some said they have to report credible allegations of fraud. So it gives another place to make that judgment call and not report. There's also a wide range of timeframes. Some say you got to report it within 1 day to your state. Some give them 270 days to report potential fraud. Some states don't really specify what happens to the plan if you don't follow the referral requirements. And OIG wants CMS to work with states to make sure that Medicaid managed care plans have to report instances of fraud and lay out the details of what happens if they don't. Last item here in Reform News, I'm not going to do a lot of detail on this one, but I do want to do a quick call out to item 22 in your Intel report, how state directed payments turn Medicaid into an interstate transfer scheme. You've heard me talk about for years how we have all these financing games. It's really just used to maximize profit, all under the myth that there's not enough spending on Medicaid and on Medicaid and all these other different places. So state-directed payments are one of the financing games I've talked about in recent years, and of course, under fire and HR1 reform. This is all separate from work requirements and the provider tax stuff we're talking about. And if you're interested in kind of getting outside of your echo chamber and seeing what some other people think along these lines, I highly recommend checking out item 22 in this week's Intel report. Let's look at fraud real quick for the week. Last but not least, let's do some fraud highlights / lowlights, and you can check out all the detail, all these stories in Intel report if you want to read all the sordid details. We're just kind of summarizing it here, but I do want to call out some of the changes the team has made over the last couple of weeks to try to get more of the nuances of fraud reporting into this. So you can see the color coding now includes if it's yellow, they've been charged. If it's red, they've pled guilty. If we've got the blue diagonal lines, they've been sentenced. So just want to give a quick shout out to the research team doing this. This great job helping us understand this as there's more attention on fraud. Some of the lowlights, you'll find some HCBS waiver fraud in that Intel report in Indiana for almost, I think, $11 million. Yeah, $10.9 million. Some substance use disorder treatment fraud in Kentucky for almost $5 million. See a couple other things across different states. But if you want to stay on top of this, just check out all the details in your Intel report. And as I've reminded you for now 20 years, don't forget you pay for each and every bit of this. And usually there's going to be a member hurt physically. A lot of times there's member abuse at this. At a minimum, these are services that are not going to a member as they were designed. Let's move on real quick. Or actually, now we're going to jump into our guest interview, talk with Sandra this week, and then when we come back, we'll do closeout.
Next, we're talking to Sandra on this week's episode of Medicaid on the Brain. Sandra, thank you for being here. If you don't mind doing a quick self-intro, whatever you want our audience to know about yourself and your organization, and then we'll cover some of the stories you wanted to cover.
All right. Thanks, Clay. I'm Sandra Berg. I have a counseling license in the state of Kansas and have been a provider for probably 15 years. Serving a lot of the Medicaid population, and then went over to managed care, and I was in managed care for 10 years. Currently, I'm serving as a chief administrative officer of a not-for-profit who serves people with substance use disorder, and also we have a contract with the state of Kansas to provide foster care homes, and then also to work with families who are at risk for having their children put into foster care. So that's a brief snippet of who I am and what I've done in my vast career.
Thank you. And if we have a little bit of time at the end, I'd like to hear a little bit more about DCCCA or whatever, because I started to look up you guys. I'm like, this is an interesting animal that I haven't necessarily seen before. But let's try to maybe keep a couple minutes at the end, if that's okay. All right, one of the first ones you want to talk about is Georgia Medicaid insurer reverses 20% therapy rate cut, but not for all providers. The quick setup, this is CareSource in Georgia, and they were going to execute on a reduction in rates for some therapists. They're backing off of that. If I read it correctly, for the ones that are in like provider shortage areas, but I think it's going through for everybody else. What do you want to talk about on this one?
When I first saw this, and Georgia wasn't the first state I've seen this happen in, it really made me think about the actual state contracts that are across Medicaid states and how they vary in the flexibility that the managed care organizations have when it comes to setting rates, what their benefit cost ratio is. So not to get too technical, but benefit cost ratio is how much can you keep in relation to what the state's paying you for your contract. So some states will set that at a pretty high level, some states will not. And if I remember correctly, Georgia didn't have a very high threshold. So there was the opportunity for managed care to go in and cut those rates so they could earn a higher return. In the state that I worked in Kansas, primarily, we had a very high BCR that we were required to maintain. So I think it was around 85% of the dollars that we were given had to be spent in the populations that we were serving. What that sets up is that ability for the ability for the managed care organizations to serve the population, but it also sets up for potential cutbacks to the providers in that state when it comes to really high cost members. My background's in behavioral health. When I would look at our total cost of care for populations, behavioral health was always a very high cost population to serve because a lot of times they have complex conditions. They have other needs outside of going to see a provider. They may need housing. They may need all of the, what we call the health risk factors that would play into their health across the board. So when I first saw this, I thought, they're looking at their data. They're looking at, okay, where can we cut costs to help our margin. And I'm not picking on CareSource because I worked with 3 different managed care organizations, talked to others, but it is about how can we serve a population, stay within our contract, and also how can we keep our doors open and meet stakeholders' requirements. CareSource is a not-for-profit. Their profits go back into the company. When you're working with other managed care companies, they have shareholders, they have expectations too. So it's really that balance. And it really goes back to those individual state contracts and what the contracts will say. Some of them will set a limit on the profit margin that you can claim.
Right.
Claim is a loose term. And some of them don't. So I just thought it was interesting that this one came up because I think when I was working on a contract in Georgia, I didn't ever see a limit to their BCR. So.
And I think this sounds very similar to what I, in my world, talk about MLR, like a medical loss ratio.
Right. Yeah. It's the same thing. Yeah.
Yeah. And I'm glad we're talking about this because, there's another story also with CareSource in Ohio. I've been following over the last couple of months. Similar thing, like they were going to do a provider cut, and then there's like protests, like literally protests outside the Dayton office.
Right.
And in that one, I think it was something that they're essentially just paying the policy, like they're executing what the state said you had to do with these. So they're like, hey guys, we're just doing what the state says. But if I'm understanding what you're saying correctly, there in this example, they may actually have some leeway where they could just be squeezing providers from a margin play, and they don't have to do this.
Well, and I think there's also that advocacy because like in Ohio, there might have been groups advocating that these cuts not be happening, or they may have gotten to the legislators. I don't know how all the states do their oversight, their legislative oversight with Medicaid. They're all different, obviously, but something could have happened in Ohio that may not have happened in Georgia as
Right.
far as the advocacy piece, and providers knowing that they can go talk to their legislators, they can go talk to their state officials and say, this is what's going to happen. This is the downstream effect of what's going to happen with these cuts. Start cutting providers' pay, you start cutting and actually taking money back. The damage is long-term because it takes a long time to build that back up. And there may not be requirements there may or may not be requirements within the contract around provider networks. So again, what are you doing in the grander scheme of things? And what's going to happen downstream when you start making these cuts?
Right. Thank you. Let's talk about this next one. Pennsylvania announces 42 million for rural healthcare projects. I was looking at this one this morning. I mean, they've gotten almost 200 million bucks under rural health transformation. This is kind of the first tranche of that. And I think it's going to be 66 different projects. I didn't see a lot of detail about what they're going to go for. I mean, there's some high level stuff, but what do you want to talk about on this one?
Yeah, Kansas also was awarded 221 million. So I think what's happening with these grants is, again, it's directed by HHS and the feds, but it's allowing the states to have that somewhat autonomy, but they're going to have to answer for the outcomes of these grants, and really looking at how can we utilize these dollars to build up an infrastructure, especially in the rural areas where it's been a struggle to get people services. So living in a state where half of the state, there is more cows than there are people, and living in the other half where it's pretty populated, we looked at how can we utilize what is already available and help shore up the rural areas. And I think it's going to happen, but what I'm reading about these different awards and how they're handling them, it's going to be very, very disconnected, sort of, because I don't know how the feds are going to collect data when all of these projects are going to be different.
Right.
So I'm kind of a data nerd, did a lot of work in research. And if you don't have some consistencies, how are you going to measure that this is actually working?
That's a very good point, and it kind of dovetails into some things we were hearing early on when the initial, hey, there's going to be billions for rural health transformation. But you're right. I mean, even just on the list that we have for this one is workforce and behavioral health and maternal health and aging. Those are all very different things, and that's just one state. And
right.
Who owns the or does that even happen? But it makes me think about several months ago we were hearing that effectively large hospitals in each state were intercepting a lot of this money anyway. So like a lot of times this is really, I'm trying to think of the right phrase, putting lipstick on a pig, right? It's a lot of money. It's getting pushed out, and we're all going to pretend there's a story here about what it's going for, but really it's going to your local giant hospital first and foremost, and then some of it will trickle down to like actual rural. But you raise a very good point about what are we going to end up with on any type of measurement, like especially with this like wide range of things. That's a very good point.
Right. Well, and the way things were selected here, I'll only speak to Kansas, and I imagine Pennsylvania was the same way, is that it was kind of a who could advocate and who could lobby the most to get the dollars. Like you said, it might have been a large hospital system that was maybe investing in a smaller hospital. So yeah, it'll be interesting to see how this all comes out in the wash, but I'm a little skeptical.
Yeah.
Great to have the dollars, but
if you're not skeptical after like just a few years in this space, like you're just not paying attention. The next one you want to talk about is Amita launches, I guess, Sarah Swati. I don't know if I'm saying that right. A real-time HEDIS measurement platform for health plans and MCOs. I mean, I flagged this as a lot. A lot of these that we get are like basically press releases, and people really want to know about the solution. But what are you excited? What do you want to talk about? Is this something you're excited about? Something that you've got experience with? Something you don't like? What do you want to talk about?
Yeah. So my first job at managed care was working with HEDIS measures in behavioral health space and tracking our outcomes and what we were doing to move the needle. And one of the challenges, and they're still going to have the same challenge, they may have real-time quality measurements that'll hit the plans faster and be more up to date. However, there's still going to be that delay in billing claims. And so I think it's great that they're going to have something that's a little more readily available, but you're still going to have claims delays that are going to come in, anywhere from 90 to 180 days after the fact.
Right.
So to say this is going to answer all the issues, I think is a little misleading because, again, we experience claim delays all the time. We would do, HEDIS activities to make a difference. And until the claims came through, we didn't know whether we were making the difference or not. So I think this is good. I think it's going to be good for the health plans and also for some of the providers that are watching HEDIS as well too. And as far as the states go, getting those HEDIS measures earlier, but still with a little caveat that you still have billing delays. So and that's going to start at the beginning of the process.
Somebody still got to do that claims lag triangle. I may be dating myself, or IBNR.
Yes,
so
right.
That's still a thing. And we're all still going to be chasing a few numerators in Q4.
Absolutely. And, yes, remember doing the chart chases and all of that work that went into that. So I think it's good, but yeah, I'm like I said, I'm a little skeptical.
Right. We've heard this before. And it does the dishes. That's all the videos said. Next one, Colorado Medicaid owes feds $8 million. Again, I was looking at this one this morning, and the gist of it is, if I remember, this is in-home care, largely, I think, for IDD members. And essentially, the state is supposed to have the caregivers log into a system that shows like location data. This is one of the first things in the cycle of like the big EVV push or whatever. If I read it right, the system they have didn't have like a GPS component, and it by the time you trickle it all down into what was sampled and all that kind of stuff, it's about $8 million feds. What's your take on this one?
Well, when I read this and I saw that they reviewed a sample of 160 claims, that was a red flag for me. So oftentimes what happens is they'll take a small sample and then they'll extrapolate it to the whole population. I think some of the approaches that are being taken are like swatting a mosquito with a sledgehammer. So what are we doing? What are we doing to the good players that are not trying to defraud the federal government or the states, but this is going to impact them as well.
Right.
So I really struggle with the whole concept of, the whole state's committing fraud. Yes, there are bad players, and I've worked with providers when I was in managed care that were not following the rules. And we address those in that concept. But to say this for the whole state and to extrapolate out from 160 claims across 1.3 million claims, that's quite an extrapolation. So that was my thought around that one. I was like, wow. Yeah.
Thank you. That gives me two thoughts there. One is Mike Johnson, if you're listening, he taught me a whole lot of what I know about Medicaid claims data, including on the state side. Now, this is a little different what I'm saying, but like when a state finds provider Clay, in the wrong or whatever, including like there are approved sampling methodologies to then extrapolate that across the whole set to figure out what provider clay owes, or whatever. But
Right.
you made me think of another thing. Like, we're at the stage now, like with AI, I don't think we even have to be sampling it all anymore. We should
Mhm.
be able to take all these 1.3 million claims, feed that to the robot, and have a better idea than just like extrapolating a sample.
Yeah,
I bet
absolutely.
that's where we go soon.
Well, and again, what's on the other side, what's going to happen with those providers that are providing those services, um, and they stop? I mean, what happens to those people that are receiving those services? And that's kind of where I get to when I see it kind of, and I've been in this situation. I had a provider that was audited. They did a sample of the claims. They were going to extrapolate to the whole system. I knew the provider. I knew the work that they were doing. I knew the services that they were targeting. But if they had gone through with what they wanted to do, it would have crippled that provider. They would
Right.
not have been able to provide the services that they needed to. So I objected to it, and much to some people's chagrin, I did get my way. But we have to think about what are you doing to the whole system? Yes, people who do things that are untoward, illegal, however you want to put it. Yes, we need to address that individual or that organization, but let's not punish the whole system because of that one. It's kind of like the bad apple example.
Any ideas on how to balance those two? I mean, because a lot of times we're not talking about just money. A lot of times there's like physical member abuse, even
Yeah,
separate from the fact that the money, if it's stolen, was designed for services. But any pointers on how to balance, like how do you
I
know when
think,
to pull back versus
yeah, I
investigate?
think, well, for me, it was listening to the local people who knew what was happening and listening to the receivers of those services, what is really happening. You brought up AI. I think with the integration of AI into more of how we do business in this field, it will help with that to kind of glean out what's really happening. But sometimes, we the word fraud is used a lot, which means intent. So were they really intentionally trying to defraud the Medicaid system or the federal government? Or were they uninformed? When you talk about in-home care programs, you're talking about folks who don't have a lot of education or a lot of sophistication. Maybe they're just not doing things right and need to be corrected. So yeah, it's a very complex issue. I think that we do need to be more accountable for how dollars are being spent and make sure that they're being spent correctly. But again, let's not kill the mosquito with a sledgehammer. It's
Could
gonna be
you
a lot of
imagine?
damage.
Could you imagine how much we could pay the good providers if we could stop paying the bad providers?
Oh, absolutely. Yeah, I mean, rates would go up and things would be
Right.
much better, but yeah.
Let's see. I think we had one more in here. So item 13, I guess it's Idaho's Department of Health and Welfare announces work requirements for Medicaid expansion. I mean, I think this is, every state is, some of them faster than others, are rolling out, their compliance with HR 1.
Mhm.
Anything different about this Idaho one that you wanted to flag for us?
Yeah, it sounded like they had a pretty good system for collecting the data. And that was the one thing when, again, being from Kansas had considered a work requirement was how do you collect the information?
Right.
So, you either are working, you're going to school, or you have a physical disability that prevents you from working. So how are you going to get that data? And who's going to collect it and where does it live? So those are the things that I was considering when I read this one and looked at what was happening in Idaho. It's happening in a lot of states. I just read another article. Nebraska is trying to work through this as well too. But how do you manage that? And is the cost of managing it equal to the return for the Medicaid system. I think that's what it kind of boils down to. Are you spending more money and not getting any results?
Yeah. I mean, my question here has always been, why are we not using the existing Department of Labor unemployment systems? And why are we not using the existing like DOJ, like sentence to community service? Like there is existing tech that's collecting similar data. I don't know what to do on the education one, because like you would have to get into attendance of college classes or whatever. But I mean, I can speak personally. There was a time in my life I was on unemployment. I had to call once a week and say I did or did not look for job. Why can't, and I think every state has that. Why can't we use that? That shouldn't be an additional cost to the system. And why can't we do the same thing for, the courts community? Like there's existing community service tracking stuff. So I don't know. I'm skeptical of
Yeah.
there's a big lift here. It's just a matter, we might just need to use tools that we already have in place.
Well, and who's helping these folks get to the point where they can work? Do we have the right supports in place to get them the job readiness, or get them to a place where they have a job that's actually going to be a living wage? I mean, in the work that we do here, we have a transitional housing program where one of the components of being in the house is we train you, we work with you, we help you move into that space of being able to work, following your recovery. And if you have kids, I mean, there's so many things that conflict with this. I mean, if you have a single mom who's got kids and she has to work, but she only makes a minimum wage, she can't afford daycare, it's that never ending cycle. How do you break that and help people get to a place where they can sustain a decent cost of living and wage? I mean, it's just, yeah.
What percent of the people that you serve do you think are in the ACA adult expansion group?
Very little. We have very few.
Well, that's good,
Most
because
of
that's
them
the
are,
only people that work requirements apply to, is if they're
Yeah.
in that group. So for your population, this is really, work requirements for Medicaid is really a nothing burger. I'm not saying it is for others,
Right.
but that's good. That's good for you guys. You don't have a lot of impact.
Yeah. Yeah.
All right, give me 1 minute. I said I wanted to learn more about your organization because it seemed different and unique from what I'd seen before. So if you don't mind, give me 1 minute on that, and then you got to answer the how full of it is clay question.
Okay. So we do have, like I said, we have kind of actually three legs of our organization. One is we do a lot of prevention work. So we're out there teaching people how to use naloxone. We do a lot around traffic safety, seatbelt safety, just a lot of prevention. We work with organizations to understand substance use and what their beliefs around it is and how we can break down that stigma. So that's the prevention part of it. Then we have our child placing agency who recruits families to be foster parents. We do not case manage those kids. That's another contract that somebody else has. But we recruit foster families and help kids find the homes that are in foster care. And then we have our family preservation programs, which helps keep families together. It may be because of substance use treatment or allegations of abuse, whatever it is, the families are at risk for being disrupted. So we work with those families through our programs to keep the kids, in the home, but we want to make sure they're safe too. So that's one of our programs. And then we have a full spectrum of substance use treatment for both men and women. Our two women's programs are operated with an on-site daycare center for our residential. So the moms can, even the dads, they can bring their kids to the facilities. We have two facilities in Kansas. And they can bring the kids can be in daycare while the parents in treatment. And then we just opened up 10 units of transitional housing for women in our Lawrence location. And we have two people that have just moved in. We're really excited.
Cool.
And we work with them in a program that helps, job preparedness, if you're getting ready to go back to school, helping them with budgeting and finances, and we kind of work with them where they're at. So their programs are kind of self-directed. So I think, yeah, that covers it.
That's cool. I mean, y'all do a lot of things. I mean, I'm hearing basically foster care, family related services, and a lot of substance use treatment. So, I mean,
And they
there's a
cross
story,
over.
and they cross
Yeah.
over, right? There's
Yeah.
that story. And then also on what I see online, like in multiple states, Kansas, Missouri, and Oklahoma. So there's like a story there too of how you got to
Right. Yeah, we look for the opportunities that we can go into a state and provide the services. We're not trying to become the answer for everything in a state, but we want to look at here's what we have, here's what we can offer, and let's see how we can partner. So our
Excellent.
primary work is here in Kansas.
Well, thank you for doing that work. My
You're
team will be
welcome.
the first to tell you I'm a sucker for foster care. Like
Yeah.
we've helped a few agencies over the years. And I'm just like, I don't care, just do it for free. And a lot of that has to do, Mark Washington, if you're listening, that has to do with you. You got me in love with, I don't know if you know Mark Washington or not, but he's done a lot of foster care stuff. But okay.
Yeah.
All right. Scale of 1 to 10. How full of it is Clay Farris?
I think you're pretty genuine. Well, you might be full of a few things, but
Well, we need a number. Kinsey does this dial. She does
oh
this
gosh,
graphic.
okay. Full of it means that you're just all BS, and not full of it means okay. I'd put you maybe at a 2.
All right, higher's better now. You can still go higher if you want. All right, we got a 2. We got a 2. Sandra, thank you so much for being here today. I appreciate the work that you're doing in the space, and thank you for talking about these news items with me. Thank you.
I appreciate you. Thank you.
Just a quick plug for Job Hunter. These are in your Intel reports each and every week. A lot of people come to us over the years and say, "Hey, Clay, do you know anybody who's hiring?" Or, "Hey, Clay, do you know anybody who's looking for a job?" So we try to put that into. You'll see it customized for each of your different Intel reports. So take a quick look at the screen. You'll see the kind of stuff we found this week, but also look for the details and how the team is putting that together in your Intel report itself. Now let's do acronym of the day. This is going to be HEDIS. So for folks new to, if you've been here for a hot minute, you know what HEDIS is if you've been anywhere near managed care. Been around a long time, but if you're newer to the space, you may not know what it is. It's HEDIS. It's Healthcare Effectiveness Data and Information Set. And this is how we measure the quality of care delivered by health plans. So there'll be specific measures. They're defined in a specific way. And you're going to, like very specific calculations. Like you'll see things in the numerator and the denominator, and they'll get defined very specifically by NCQA. And they have to be officially certified by people who have those types of certifications. But states will use them. Check out the infographic up on the screen. I'm just kind of riffing and giving you a high-level summary of this just from my experience. But states will use them for withhold measures for managed care plans. CMS will use them to kind of overall estimate the, say maternal and child health in the program or other things. Been around for a long, long time. Hundreds and hundreds of measures. So check that out. HEDIS, HEDIS. You can think of it as a report card for health plans. And you'll always see vendors trying to help health plans out with this. And you'll always see, Sandra and I talked about this a little bit in the interview, but you'll always see chasing at the end of the year, trying to get those measures look a little better, looking for members that'll meet the different criteria and show that we kind of close gaps in care. All right, next up, let's do Mission Possible. If you're new to the club, for the Medicaid On The Brain Club, you'll know that each and every week I do something small. I recommend, hey, go outside or water your plants or things like that, or check out this new album. This week, just something to kind of break us out of our normal. But this week, I'm actually going to point you to something that is work related. Do a puzzle. The team puts out crossword puzzles in the Intel reports now. This is actually a reboot. So we used to do these 20 years ago. It was a way to just kind of get people to engage. So usually it'll to engage with the news stories. Usually they'll touch on things that are in the Intel report or something that I covered here on Medicaid On The Brain. But check those out. If you still got a printer, print one out, fill it out. Would love to see pictures of ones filled out in the comments or just email them to me or whatever. They're a lot of fun. Hopefully it's a way to give you a little bit of break, but still keep Medicaid on your brain. And that's it for this week on this week's episode of Medicaid on the Brain. I hope it's helpful for you. Thank you so much for all the work you're doing in the Medicaid space. I know it can be challenging. I know it's complicated. I know it's a lot of work. But thanks for being a part of what we're doing. And until next week, I'll see you next week. But until next week, I'm Clay Farris from Medicaid on the Brain. Have a great week.